So good evening, everybody. Welcome to ECIO 2021. This year we have introduced a new session time, which is Meet the PI, where we actually give the opportunity to main investigators of very interesting research studies that are about to start or that have already started to share both their protocol, but also their experience in building such trial and what are the difficulties and that they had to raise this kind of program. So today we have the chance to get Professor Guyu from Montpellier that will share with us a very interesting clinical study of combination of ablation with immunotherapy. I'm with Philippe Pereira today to share this session, and we are all yours, Boris.
Thank you very much, Alban. Thank you very much to all organizers for the invitation. I will hopefully start the right PowerPoint file. Okay. So the objective of this study, this study is mainly dedicated to a small HCC, and especially in the field of ablation. And this is the ABLATE-02 trial. I would like to start to take a little bit time to explain the rationale of the study. The first point is ablation has become the first curative treatment of HCC. This is very important for us, and we have just published this paper showing the different treatment options for the patients with HCC, options obviously with intervention, but also with surgery. And as you can see, over the past 10 years, ablation increased steadily from 2013 to now. And now, if you look at those figures, you can see that whether we are in the whole population or in cirrhotics, in both cases now ablation has become the first curative option far beyond surgery. This is a very important point. But it means that we have to focus maybe a little bit more on our results. And if we go more deeply to our results, with ablation, we have two problems, which are very, very different. The first one is local recurrence. As you know, local recurrence occurs between 5 and 20% of cases, and it mainly relates on our ability to obtain adequate margins around the tumor, and it's probably more a technical problem than an oncological problem. And what is very different with the distant recurrence is that local recurrence is, in most cases, ablatable again. So this is not really a problem. And it is very different story with intrahepatic distant recurrence. The first point is that, as you can see, it occurs very, very frequently. I would say it occurs in every patient. And the debate is great between what is the origin of this recurrence? Is it a metastasis or is it a de novo HCC? This is a good question because we are in most cases in the context of cirrhosis, and it is important to know about what we are fighting. In this paper, we aimed to look at many factors related to the patient, to the disease, to the tumor, and technical factors. And the objective was to find what was associated with the occurrence of distant recurrence. And as you can see here, we found only two factors associated with distant recurrence, AFP and tumor size. So in a way, these factors are reflecting the aggressiveness of the tumor and are more in line with the concept of metastasis, at least during the first 2 years, because as you know, after the first 2 years, there are some data in the literature showing that de novo HCC are probably more frequent. So at the beginning, I would say we need to fight against the metastatic escape and against tumor growth. And this is very important because, as you can see here, and this is very different from local recurrence, in the case of a distant recurrence, there is a high risk for us not to be able to treat the patient with a curative approach. There is a drift to palliative care. There is a drift to a palliative prognosis. And probably this is the key time where the patient is losing a good prognosis. So we have to fight against this event of intrahepatic distant recurrence, and this is a very important rationale to support the trial we'll present in the following slides. Just to go a little bit more deeply into recurrence, but not only recurrence, but also death. If we look at the literature, the recurrence-free survival at 2 years is, I would say, only 45%. It means that only 45% of patients after ablation are alive without any recurrence at 2 years. It's not that good. Obviously, with resection, it's exactly the same story. But it means that there is clearly room for improvement. And that's the objective. At the same time, as you know, last year there was a big new challenger in the field of advanced HCC with the combo atezolizumab and bevacizumab, this anti-PD-L1 and this anti-angiogenic, which show synergistic effects. We have no time to discuss about that. And when you look at this panel, you can see on the updated results of the IMBRAVE 150 trial, just communicated at last ASCO GI, they reached 19 months as compared to 13 months with sorafenib, which is a huge difference. But more interestingly for us, if you look at the response rate and the objective response rate, 30% upon RECIST in advanced HCC, it had never been shown before with any systemic treatment. So definitely and clearly, this combination is working very well, and might be interesting to use it also in BCLC-A patients. Why? Because there is a strong rationale to combine immunotherapy and ablation. You have here in this paper some data, and it is interesting to see the reason why. To make it simple, when you ablate the tumor, there is the release of peptides, of proteins, and especially headshot proteins, but not only headshot proteins, but also glypican-3 and many others that are able to activate the immune system. At the beginning, the innate immune system, and then the adaptive immune system. This has been shown in many, many publications. And in this one is very interesting. This is a paper focused on colon cancer, but they looked at patients treated by RFA, and they showed that the T cell subpopulation were completely different in those patients previously treated by RFA as compared to the others not treated by RFA. And they concluded from this first part that RFA elevated T cell immune response in the tumor microenvironment. It was very interesting. And then they go to an animal model with a mouse. They induced one tumor on each flank of the mouse, and they treated one by RFA, and they looked at what happens on the other side. And you have here the curve, and you can see that on the other side, so the tumor was not treated by RFA, but the contralateral was. And you can see that during the first 6 days, tumor growth was inhibited. After the first 6 days, the tumor regrowth. So it means that during the first 6 days, something happened due to RFA alone. And they could show that it was certainly due to a strong CD8 plus T cell immune response. But on the other side, after 6 days, the tumor regrowth. And the reason for that was that not only RFA induced a T cell immune response, but also PD-L1 expression that was increased. And as you know, PD-L1 is a strong inhibitor of activated T cells. And maybe this induction was designed, I don't know if it's the right term, to self-limit the mechanism. But the idea behind was to administer, in addition to RFA, an anti-PD-1. And you can see on the red curve here that the tumor growth and the tumor control was the best, was excellent when we combine RFA to anti-PD-1. And when you look at survival, we have exactly the same results. So there is a strong rationale to combine RFA with a blockade of the axis PD-1, PD-L1. many data now are available, including clinical data, but no randomized trial has been published on this kind of approach. And this explains why we designed this study. So now you have here the simplified rationale. We are within the indication, the validated indication of ablation, 1 to 3 HCC nodule, small HCC less than 3 cm. In the standard arm, we ablate the patient with RFA and then we follow up the patient, I would say as usual. And in the experimental arm, we perform an induction with neoadjuvant atezo, an anti-PD-L1, then we ablate, and then we treat the patient by the combo atezo-beva for 1 year. This is the rationale. What about the hypothesis? As we discussed previously, the objective and the primary endpoint is RFS at 2 years, and we want to improve this RFS. In the literature, we had 45%. We want to extend it to 65%, which is not that optimistic. And with the usual hypothesis, statistical power, alpha risk, loss to follow-up, and no interim analysis, we need to include 202 patients. And with a 1-to-1 randomization, it means that we have to include 101 patients in each arm. What is important is that in addition to the primary endpoint, we have to look to overall survival at 5 years, because we have a chance, provided the results are positive, to change the game in the BCLC-A patients based on the results of this trial, obviously provided the trial is positive, but we need to look at OS even as a secondary endpoint. We will follow up the patient using MRI every 3 months, for the lung using chest CT every 6 months, and any other examination if necessary, following international recommendations. We include in this trial quality of life because it's very important to see if there is an impairment of the quality of life, because in the experimental arm, we have not only ablation, but every 3 weeks, the patient must go to the hospital to get immunotherapy, and this may impair quality of life. So this is something we need to look at and to see if the balance, even though the trial might be positive, is positive for the patient. So this part of the trial is very important. You have here summarized our main objective. So again, this is a comparative randomized trial on RFS at 2 years. We also look at the central review, compliance, tolerance to the treatment, quality of life, incidence of recurrence, time to recurrence, overall survival, and a very important translational part that I will show you briefly here. So to enter into the trial, we need to biopsy the patient. It is mandatory. And we have many examinations based on tissue, as you will see on the next slide. We rebiopsy the patient during RFA in the experimental arm after atezolizumab treatment. And we rebiopsy, but this one is optional in case of recurrence. And we also have blood samples at many time points, at the beginning, obviously, but also after neoadjuvant atezo, after every sessions of atezo-bev, and in case of a recurrence. You have here some of the data we are looking at, both on tissue, as you can see here, and on plasma, including ctDNA, including mutations, those known and those which we looked at based on exome analysis. We will look at RNA-seq, at PBMC, cytokines, chemokines, growth factors, many things which are clearly included and funded in this study. So to complete this trial, we have 16 centers involved in France. Now 3 are opened and the others will be opened by the end of this month. The inclusion period is 18 months for the patient, so we need to go fast. And then the patient must participate during 2 years to reach the primary endpoint and 3 additional years to reach the secondary endpoint of overall survival. And to conclude and to keep the time, I would say RFA so far is the standard and the first treatment of small HCC. Atezo-bev has become the new standard in advanced HCC. We think that neoadjuvant atezo and adjuvant atezo-bev might decrease the risk of recurrence and especially the risk of distant recurrence because of synergistic effects that we strongly expect with RFA. We discussed about the design of this randomized trial. We expect the final results for 2025, in 2025. Thank you very much.
Thank you, boys. Really an exciting topic and a very good question that you expect to answer, that's for sure. I have just one small concern. I perfectly understand that most of the literature for ablation of hepatocellular carcinoma and also the experimental studies are based on radiofrequency, but many of the centers moved to microwave now. For good and bad reasons, for sure, but that's the reality of the market. So if your trial ends up to be a positive trial, that would mean strictly that we should have to step back and come back to radio frequency at the end, because nothing proves that microwaves will give the same results in terms of immune stimulation.
I'm perfectly in agreement with you. This is a problem. Among the 16 centers, we had some of these centers using only microwave ablation. And the question for them was, okay, should I go back to RFA? And I had many discussions with many centers. Can we include and can we allow to treat the patients with RFA or microwave? And clearly, I looked closely at the literature with myself and my colleagues, oncologists and specialists on immune response. And there is I would say, a poor rationale for microwave as compared to RFA. Maybe there is one synergistic effect, but clearly we have much less data. So your question is very important. And some of these centers had to go back to RFA because they wanted to include in this trial. And as you said, if the trial is positive, we have two options. Everybody should go back to RFA, or we can conduct the same trial based on microwave. And the last point was with ablation, we have also cryoablation, we have also electroporation. Yeah. And in an ideal world, I would have chosen electroporation because there is even more rational to use electroporation with immunotherapy. But clearly, this approach is too complex, too long, and not widespread. So the second on the list was RFA, and we had to focus on that. But this is clearly a good question.
First of all, I want to congratulate you and your team because it's an excellent, interesting study, first of all. Prospective randomized study is very good. First question is regarding the ablation. We all know that ablation of HCC with RFA and the immunologic response, there is a lot of debate about complete ablation or incomplete ablation. And, I let a little bit of the tumor because I need it for production of antigen, etc. How will you deal with that, and how will you monitor? Or is that the aim, to complete ablate versus not complete ablate?
Philippe, thank you so much for this excellent question, because when we discuss with centers that are already open, I had several times the same question, and it's a very good question. There is one paper addressing this point, published in Nature Communications, which is a top-ranked journal, and they showed that if we perform an incomplete ablation, it is a very bad idea because the inflammation around, obviously inside the tumor, provoke the opposite effect that we want to get, meaning that we have an hyperprogression. So in this trial, the objective is to completely ablate the tumor. And this is clearly a problem because there is a selection bias. There is, because this is not a blinded randomized trial. So we know as well as the patient how we will treat the patient. And we might have a bias due to the fact that, okay, I know that we will use immunotherapy. So maybe I will not be that efficient onto the tumor because I know that I have immunotherapy before and afterwards. The problem is that it has been shown this is a very bad idea. So the advice I discussed with my colleague co-investigators is please do ablate the tumor as much as you can completely, exactly the same way as you would do outside immunotherapy. This is a very, very important point.
And the following question is very similar. You include patients with up to 3 nodules. For me, on a scientific point of view, could be very interesting in this patient to ablate one HCC, to make a biopsy of all 3 nodules, and to ablate only one and to see what happened with the other one. Yeah. For a sub-analysis by 202 patients, for the sub-analysis, that could be a very interesting aspect.
Yes, I agree. And in this case, it is fully acceptable because there is no inflammation in the tumor. We only treat one, and we expect to look something in the others. So clearly, this is a very good question. But unfortunately, we did not design the trial like that. Again, the objective was to focus on not on how we can obtain a response on other tumors that are already present, but how we can reduce the risk of occurrence of a new HCC nodule. But clearly, your question is very interesting, but it would require another trial. That's something we could look at because it's also interesting, and I think it should work because of this ability to have synergistic effect between immunotherapy and ablation, but because also of bevacizumab, which is an anti-angiogenic itself, and atezo itself, and the combination. So there are many reasons to think that if we ablate one nodule, maybe we could have a response on the others.
I have in my hospital a very active immuno-oncologist, and we always discuss without really data on that, the combination of immunotherapy and ablation in HCC. We are also discussing that point for other tumor entities, but for HCC. How did you decide the timing for atezolizumab and bevacizumab in the adjuvant setting after ablation?
Again, very good question. Thank you. So,
sorry,
very good question. Atezolizumab, at the beginning, you have 2 sessions of atezolizumab every 3 weeks, and ablation must be completed during the next 7 days because we want to still have some atezolizumab circulating and to have this synergistic effect. So we need to do our ablation close to atezolizumab administration. And as soon as ablation has been done, during the 10 following days, we must start atezo-bev. So the objective is to have always atezolizumab plus bevacizumab circulating to obtain the most important synergistic effect between both treatments.
Do you know the pharmacokinetics of atezolizumab, the minimum concentration, how long, how many days? No. I'm afraid nobody knows.
No, probably, but myself sure.
Okay, it's really a fantastic study, and we can only encourage all interventional oncologists to discuss with their oncologists and immunologists to start this kind of study. And of course, my last question, because time is almost over, my last question is: how do you have a financial support for this kind of study?
Yeah.
Do you pay the drug?
Yeah. Okay. So the financial support is 2 entities, my hospital, a little bit, but my hospital participated in the study, and the rest is funded by Roche.
Okay.
So we were lucky because we had many discussions with Roche before the results of the positive phase 3 long before, and they were attracted by the concept, and they accepted to fund a large part of the study. It is, for us as interventional radiologists, it's very difficult to have contacts with big pharma companies and to
It's correct.
To be able to conduct and to get some enough funding, because the drugs are also funded by the study.
Okay, but we can stimulate the pharmaceutical industry, because in that indication, normally this systemic treatment is not indicated. So it is an additional indication for the treatments. Very good. Very nice. I can encourage you maybe to look at HCC up to 5 centimeter by combining immune therapy with ablation and maybe with microwave ablation. It would be also a fantastic study to treat patients with HCC up to 5 centimeter with curative intention. Could be very nice to have this combination. Boris Gouillou, thank you very much from Montpellier. Thank you very much. And I'm happy that we have this new session. We are happy to have this lecture on the ECAO online. And I say everybody good night and good evening and good night. Bye-bye.
Bye-bye. Thank you very much.